Okay, Assalamu alaikum wa rahmatullah. Okay. So this is a follow-up lecture. And again, to remind you, my name is Dr. Nader Khair. I'm a consultant endocrinologist, American board in internal medicine and endocrinology, and currently working as a consultant endocrinologist at Dr. Suleiman Al-Habib, Sahafa branch. And I send you, gave you my contact information the last lecture. So this will be the last lecture. Actually, it's supposed to be 6 lectures, but I think for this class, they made them like 3. They 1 lecture for thyroid and 2 lectures for diabetes. So I try to combine those remaining 2 lectures in 1 lecture. Okay, so it will be diabetes complication used to be 1 lecture, and approach to patient with diabetes was another lecture. So I try to combine them in 1 lecture for you for the sake of time. Okay, so last lecture we talked about the types of diabetes, type 1 and type 2. And we talked about the symptoms and presentation of patient with diabetes. And we mentioned that patient's presentation could be with a diabetes complication. So the first presentation of diabetic patients could be complication, and this is not good. We try to prevent, we try to screen as early as possible for diabetes, so to avoid complication. And imagine somebody presented with complication from the beginning. And most of these presentations that's come in the beginning, they usually is divided to acute and chronic. So also we try to prevent in the clinic the chronic complications and little bit of acute, but mainly in the clinic for chronic complications. Acute complications, actually presentations usually you see them in the ER. So and then at the end we'll give you an approach and some questions about these presentations. So to divide diabetic complications, the easy way I find is divide them to acute and chronic. Acute, that means you have to deal with them right away: diabetic ketoacidosis, hyperosmolar non-ketotic hyperglycemia, hypoglycemia. Are you familiar with those 3 terms? Okay, there's nothing else. That's it. So this is, you have to memorize this through your career. 3 acute. Either patient coming with DKA, who's coming with hyperglycemia and he's very sick, he needs to go to the ER and need to be admitted at the hospital, but he's not in DKA. Or the patient coming because of hypoglycemia, and most of the time the reason for hypoglycemia is medications. And the number 1 medication is insulin. Very rarely it is endogenous insulin production. There is only 1 hormone in the human body can lower blood sugar below 70. Remember this, 1 hormone, nothing else, it's insulin. So if you have a patient with hypoglycemia, look for insulin, whether the patient was injecting insulin or producing too much insulin, or taking a medication like sulfonylurea produce too much insulin. Nothing else, okay? So sometimes you see patients presenting to the clinic, I have hypoglycemia, my blood sugar drop, my this. Most of this, insulin resistance, pre-diabetes, gastric sleeve, GI issues. They produce too much, they eat too much sugar, and they produce too much insulin. And they have a post-meal or post-prandial hypoglycemia. That's different. If you have true insulin-mediated hypoglycemia throughout the day, you will have fasting overnight hypoglycemia. So if you don't have that, that means there is no insulinoma. So this 1-minute talk, don't look for insulinoma. It's like a ghost. Many patients will come, I have something producing insulin. That's not true. In my practice, 30 years, I maybe 1. Okay, so nothing. Insulinoma is something that is very rare. So reassure your patients, try to do your workup. Most of the time, these patients, they will have been taken willingly or don't know that's something that produces too much insulin, or they have some sort of pre-diabetes. So acute complication, diabetic ketoacidosis, hyperosmolar non-ketotic hyperglycemia, and we call it this way because it's non-ketotic. So it just looks like DKA, but there's no K in the DKA. Okay, and there is no A, no acidosis. So no ketosis, no acidosis. You just have hyperglycemia and dehydration. The chronic complication that you will see in the clinic, and that's what try to prevent when the patient come for follow-up, and it's divided to microvascular and macrovascular. The microvascular, always three: retinopathy, neuropathy, nephropathy. So small blood vessels, that's in the eye, the kidney, and the foot. They're not going to change. That you do it as a PCP, primary care doctor. You always have to look for the eye, the kidney, and the foot. Once a year, you have to check for those. Macrovascular is big arteries. Big arteries, main big arteries, heart and brain. Heart attack and stroke. Those are the two things that send people to the graves. So you have to prevent those. Macrovascular complication of diabetes. And a patient with diabetes, even if it's controlled, they're twice at risk for myocardial infarction and stroke. So we don't want to get diabetes because it puts us at risk even if we are controlled. Now we go into details. This is the main topic, acute or chronic. So we're going to go through the acute and then followed by the chronic. Diabetic ketoacidosis, by the name DKA. If you don't have those three, your patients in the hospital or at the clinic, they don't have DKA. You have to have, the D is for diabetes. So if my patient does not have high blood sugar, it's not diabetic. So could we have a euglycemic DKA? Yes. So sometimes the patient will have euglycemic DKA. That's a rare, but the blood sugar will be like in the 150, 120, 140, okay? But they have DKA. So you have to always remember. But the patient have to have diabetes. So what you do the A1C, you do other form of diagnosis of patient diabetes, taking history, the patient is non-diabetic, other thing that's to make sure that the patient is diabetic. Acute presentation of DKA in a newly diagnosed usually is hyperglycemia. The euglycemic usually because complicated by or contaminated by other medication that lower blood sugar. So patient is taking SGLT2 inhibitors, patient is taking GLP-1 injections, and his type 1, he might have euglycemic DKA. So at D for diabetes, not for the hyperglycemia. Okay. K for ketosis. Ketosis means too much ketones. Ketone produced by fat metabolism. So the patient have to burn fat for metabolism because they cannot burn sugar. Why? Because there is no insulin. No insulin because there is no insulin actually produced, or the insulin produced is not working, is malfunctioning. So if you lose the effect of insulin, your body is going to shift to fat metabolism, producing too much ketones, and the ketone bodies are known to be acidotic or alkalotic? Acidotics. That's why the last one, A, is for acidosis. So you have to have a low pH, you have to have ketones in the blood and in the urine, and your patients to be known for having diabetes. And it's mainly in type 1 because of lack of insulin, but some rare cases in patients with type 2, they might have that because at some point they have low insulin. You need to lose 10% of your insulin capacity for glucose metabolism to develop DKA. So type 2, if they have lack of insulin for any reason, they might go into DKA. And not everybody, there's sometimes we call them type 2 prone diabetes, DKA. Type 2 prone DKA. Symptoms and signs. Symptoms and signs of presentation usually come from those three, DKA. So for hyperglycemia, give you the polyuria, polydipsia, blurred vision. The acidosis, give you the nausea, vomiting, abdominal pain. Because of the also acidosis and ketosis, you have lethargy because you are not using your glucose. And somnolence are symptoms of more severe decompensation, dehydration because of, always not memorize, try to, think through. Why we have dehydration? Polyuria because of glucoseuria. Glucoseuria becomes like a diuresis. So dehydration and acidosis can lead to hypotension and tachycardia. Rapid and deep breathing to compensate for the acidemia. That's we call Kussmaul's respiration. The fruity breath due to the acetone, because the ketones, one of the ketones. And if not recognized and treated early, DKA is a life-threatening condition and give you to coma and death. And sometimes you find, and you have to look for the precipitating factors. People forget about this. You have to look for signs of why this patient got into DKA. Infection, myocardial infarction, other things that can push patients into acute stress. So diagnosis of DKA, as we mentioned, we need to have the D, the K, the A. So hyperglycemia, more than 250 most of the time, but it could be less than that, as we mentioned. The pH have to be in the acidotic range. The bicarbonate also have to be low because it's acidosis. Serum ketones will be positive in the urine, also positive, but you have to go for the ketones in the blood. And the anion gap. Are you familiar with anion gap? So the gap between the positive and negative anions. And when we have the gap high, that means too much acidosis. The potassium depletion and hypophosphatemia. Are you familiar with the why? Why potassium depleted? Because somebody said yes. Why? So patient presentation usually in the beginning will have hyperkalemia. If you work in the ER or you have been in the ER, you see patient with DK, you will have hyperkalemia, but that's transient hyperkalemia. And that's just is part of the derangements in the electrolytes. But actually you're losing potassium from inside your body. The intracellular potassium is depleted. This is what we're talking about. And when we give this patient insulin, the hyperkalemia become what? Hypokalemia. That's why we have to compensate the potassium after 1 hour or 2 hours of insulin infusion. Clear? So the total is potassium depletion, but initially it could be hyperkalemia. Same thing for hypophosphatemia because of the ATPase working, and like the phosphates in the DNA in the metabolism, the phosphate goes down. Fluid also because of the breathing, the muscular breathing. Fluid depletion up to 6 liters, and this is very important. And this is lead us to the not only diagnosis, the management. What's the fluid depletion? Up to 6 liters. So the management should start with up to 6 liters, right? So you don't get afraid. 1 liter, 2 liters. You sometimes you're gonna need to give up to 6 liters, and that's number one treatment or management for DKA. You start with rehydration. But the patient is missing insulin. Why would you use insulin first? Let's see if I ask you, you people in the back here, please pay attention, okay? Because this is gonna be in your exam and in your life, and you're gonna save a person's life. If a patient presenting to you and you get your diagnosis, patient have a DKA, what's your first step in management? You can see this in multiple choice questions, and you can see it in life. Which one come first, insulin or fluid? Fluid come always first. And why not insulin? Because imagine you give patient sub-Q insulin, and most of the time they have been taken sub-Q insulin. Because of the dehydration, the insulin is going to stay in the subcutaneous tissue. It's not going to go anywhere. So you need to rehydrate this patient first, then you give insulin. And the insulin we give in the ER is IV insulin. And the IV insulin half-life is 10 minutes. It's not like the sub-Q like around 4 hours or 24 hours. So it's very short acting. So at the end you need to give sub-Q, but in the beginning you need to give IV. So how to manage this short half-life? We give insulin infusion. It's not insulin sub-Q. So you find a line, you put IV fluids, and then you inject at minimum 10 units of insulin, okay? And then you hand the drip, insulin drip we call it. So this is mainly the treatment of this patient. And then you manage electrolytes imbalance. And don't forget to treat the underlying cause of the DKA. Presentation of type 1 diabetes, so you have to tell the family and the patient that you have diabetes. And if the patient, and most of the time, the main reason for DKA is missing insulin dose. Which one usually? Is it the long-acting or short, the long-acting or short-acting the patient missed? The long-acting, because you're missing, short-acting is 4 hours, right? But if you have the long-acting in the background, you should be protected. Most of the time, it's the long-acting that the patient did not take the night before because they thought the blood sugar is normal or good, or I'm afraid going hypoglycemia, they didn't take it, they get a UTI, they get infection, they get something, and boom, going to DKA. So missing insulin dose, infection, UTI, pneumonia, skin wounds, myocardial infarction also. So if you have a middle-aged man, we come in with a DKA, always run an EKG. Very important. Your patient might have a myocardial infarction. Get a chest X-ray, pneumonia. Look for any infection. Urine analysis. So the treatment, we said we already went through this. IV fluids, and the choice always is 0.9% saline or saline concentration, up to 8 liters, 2 liters in the first 1 to 2 hours, and then reassess. IV insulin, correction of any electrolytes imbalance, hyponatremia. Patients with DKA usually have a hyponatremia because of the hyperglycemia. So you just need a med calculator and put the sodium and the blood sugar and give you the sodium corrected for hyperglycemia. So it's a falsely low sodium when you have too much glucose. Remember this, all your career, people in the back, all your career. Low sodium, look for the sugar. If the sugar is too high, you have to correct for the high sugar. And the MedCal, they can calculate this for you. So don't call it hyponatremia without ruling out hyperglycemia in patients with diabetes. And always treat the precipitating factors, and 12 to 24 hours to correct usually the anion gap. Patients out of DKA usually within 12 to 1 day. And you need to monitor the patient, of course. And then most of these patients admitted to the ICU. Unknown caller. And then from the ICU, stay 12 until the anion gap is closed. They transfer to the ward. So don't admit a patient to the floor unless they are capable of doing insulin drip, IV insulin. And IV insulin needs every hour monitoring. Nurse should be sitting next to the patient. If you don't have that in the floor, the answer will be admit to the ICU. Okay? The hyperosmolar non-ketotic hyperglycemia is everything without ketosis, without acidosis. Hyperglycemia, extreme dehydration, hyperosmolar plasma, absence of ketosis, and altered consciousness. And occurs mainly in type 2 diabetes, and treatment is IV fluids and insulin. Just the same treatment, just missing the acidosis. The hypoglycemia, blood sugar less than 70, and we said most of the time is insulin or oral hypoglycemic agents. And the treatment, rule of 15 grams of carbohydrates, followed by wait for 15 minutes, look for the blood sugar going up. If not, another 15 grams of carbohydrates. If the patient is unconscious, cannot take anything by mouth, you have to give glucagon injections, and that's intramuscular, or you can give IV glucose. So what the glucagon does to the patient? Does glucagon has sugar in it? What does it have? It's a hormone. So the hormone is the key for the liver gluconeogenesis and glycogenolysis. So you give glucagon, you have to have a healthy liver. You have the liver to have a person well fed. If the patient was starving for 3 or 4 days, you give glucagon, it's not going to help. It's not going to work. Okay? You have to be careful. You have to send this patient to the hospital to get an IV and get sugar immediately. Symptoms of hypoglycemia. I divided them into 2 groups because this makes sense. So the symptom of hypoglycemia is not because of the low sugar. The low sugar is doing what? The low sugar is making you stressed because your body thinks that you are in danger, you're gonna die. So you have your adrenergic symptoms. That's diaphoresis, hunger, tingling, tremulousness, palpitations, anxiety. All these signs could be when you take an exams. You will have these symptoms. You know, when your heart beats and you're going, or you're getting good news or bad news, those symptoms, that's the person of hypoglycemia will have those combination of those symptoms. Okay, and the other one is actually true neuroglycopenic. It means the nerves, the neurons are not getting enough glucose. When your brain is not getting enough glucose, you become irritated. And you become visual change, weakness, warmth, lethargy, confusion, unusual behavior, dizziness, seizures, coma. And that's severe hypoglycemia. So insulin is number 1 medication that you have to be careful when dealing with. You have always to do diabetes education, how the patient should take insulin, because if they mix the doses, if they take the long-acting instead of the short-acting dose, and they took large dose, they will go severe hypoglycemia. And always try to know the half-life of your insulin, because based on that half-life, if the patient is overdosed in insulin, you have to monitor your patient and see, like say your grandma inject insulin, and this is short-acting, like 4 hours insulin. So you have 4 hours, you have to watch her. She cannot go to sleep, she cannot see, you keep her awake, you give her fluids, you give her food, you give her sand, just until this 4 hours because that insulin. If the patient took an overdose in 24 hours, you have to go to the hospital to get admitted, because that could be dangerous, especially if in elderly patients. So severe hypoglycemia because of insulin is a very dangerous thing that we have to be very careful. Done with the acute, now we go to the chronic complications, microvascular and macrovascular. The microvascular, we divide them retinopathy, nephropathy, neuropathy. When we check for them, type 2 at diagnosis, type 1 5 years into diagnosis. Why? Because type 2 usually comes with pre-diabetes and takes a long time, and the patient might not have diabetes, has a polyuria, polydipsia, he doesn't know, he's losing weight, he's happy, he's eating everything he wants and he's not gaining weight, he's happy. So, and then patient, boom, come, A1C is 13%. So that patient, you need to do full retinal exam, because he's already type 2, he might have diabetes for a year and he didn't know, or 2 years. And that's the opposite. Type 1 usually is an acute event, so there is no enough time to develop these complications, microvascular complications. So what are the symptoms and signs of retinopathy? It's the most common cause of adult blindness. Luckily nowadays, with improvement in diabetes care, we don't see this much. Characterized by macro aneurysm, macular edema, new vascularization. And this gives you just the pathophysiology of developing retinopathy, and I'm sure the other lectures cover this. So here we're going to show you the presentation of a patient who is retinopathy, and this is non-proliferative diabetic retinopathy, and you can see the optic nerves in the middle here, and all this vasculature coming out is it's a form of retinopathy. Compare this to the proliferative, the one that's actually look like a hemorrhage. So both are signs of retinopathy that need attention. Most of the time the treatment is laser therapy. And the cotton wall spots, you can see that the white spots here. Vitreous hemorrhage, this is acute complication and acute presentation. Usually the patient will need to be seen immediately. Diffuse macular edema, also another complication of retinopathy. Diabetic nephropathy is a leading cause of chronic renal failure. So a patient with CKD going into dialysis, if you have to guess, diabetes, hypertension. Those are the 70% of all patients with dialysis. Usually the cause is uncontrolled type 2 diabetes or uncontrolled hypertension. And the problem with diabetic nephropathy, it is asymptomatic. You don't know. Some of you have diabetes, doesn't know if the kidneys are suffering or not. That's why we have to screen our patients routinely for the GFR, creatinine level, that's a serum, and the urine for proteins periodically, because the kidney is not going to say, oh, I have CKD. You are the doctor, you have to check this patient. You don't want to treat your patient, give them medications for a year or two without checking their kidney. And this is a pathophysiology, how it happened, and always is microischemia because of the microangiopathy. Diabetic nephropathy, again, screening, same like retinopathy, immediately in type 2, 5 years in type 1. And how to diagnose it? Microalbuminuria and low GFR. Treatment, usually you have to screen and prevent. Treatment of CKD usually is by prevention. Prevention for patients with diabetes, we use ACE inhibitors or R to not primary prevent, but for secondary prevention. For patients with proteinuria, you have to use ACE or R. That's the guidelines. That's the number one. ACE or R. Back in the days, we used to use them for any patient with type 2 diabetes to prevent for primary prevention. But we found out it's not helping a lot of patients, and it might damaging the kidneys. So we save it only for patients who have microalbuminuria. Stage of chronic kidney disease. So GFR usually 120 milli per minute, right? So anything between 90, less than 120 usually is supposed to be CKD, but CKD is stage 1, like 90 to 120. So, but it's good. Many of you will have like 95, it could be 100, no problem. But you have to have a kidney damage with normal or increased GFR, then you'll be stage 1. Kidney damage, whether in the blood, in the urine, or ultrasound or CT, you found a stone, you found something problem with the kidney, and you have a GFR of 90, it could be stage 1. Stage 2, 60 to 89, and many patients will be in that range, but again, you cannot call it CKD stage 2 unless you have a proven kidney damage, whether in the blood, in the urine, or X-ray. The one that you don't need to have a proof, if you find any patient with GFR 30 to 59, then they have a stage 3 kidney problem, and those patients need to be taken care of immediately. Stage 4, that's severe decreased GFR 15 to 29, and stage 5, that's kidney failure less than 15. Diabetic neuropathy, same like retinopathy, nephropathy is microischemia, microvascular complication, and the ischemia is number 1. And there's different types, depends on the type of nerves. We have a autonomic neuropathy, radiculopathy, cranial neuropathy, mononeuropathy, and peripheral polyneuropathy. And this is one of the exams that we have to do annually for our patients as screening, and then we have to do it periodically if the patient has symptoms and signs of peripheral neuropathy. That's a foot care, use 10G monofilament test. And this is another complication of peripheral neuropathy. It's called Charcot arthropathy, and that's a microvascular ischemia also of the small bones that's making you metatarsals, so break down and give it this deformity, and when you are obese or overweight, you have to push down, they become like a flat foot, and this is very dangerous. And many patients will be needing to have a cast or a boot and or canes, walker to avoid this, and this is very, I hate it. I've seen it couple of times. I hate this type of presentation because the treatment is so difficult. You cannot do surgery, you cannot do anything. So prevention is very important. Grade 1 ulcer or grade 2 ulcers, and usually in the bottom, this is very important for peripheral neuropathy and ischemia. Autonomic neuropathy, and this can become in the GI, give you dysphagia, dyspepsia, nausea, constipation, diarrhea, urinary retention, incontinence, erectile dysfunction. This all because of uncontrolled diabetes affecting your autoimmune system. Radiculopathy, that's patients which have, like, people call them sciatica or back pain. If they have uncontrolled diabetes, that could be because of the damage, microischemia to the nerve L2, L4, or T4 or T12, like if you have in the neck and the shoulder. Other neuropathy, the cranial nerve, like diplopia, if you damage the 4th and 6th cranial nerves because of the ischemia, also can develop that. Mononeuropathy, finger weakness, carpal tunnel syndrome. You can see diabetes can damage through the microvascular complication. The macrovascular complication, most of you know that MI, strokes, and peripheral artery disease. And treatment, of course, you have to control the blood sugar. A1C and cardiovascular outcome, you can see that we have to lower the A1C, especially in type 1, and I show you this in the other lecture, that the controlling of A1C can prevent you from microvascular, but for macro, you still as twice at risk for macrovascular complication compared to a normal person without diabetes. Infection in poorly controlled diabetes, also because of the poor immune system, lazy, we call them lazy, dehydrated, glycopenic white blood cells. They cannot fight infections. Other complication can have dermatological diseases, depression, dementia. In the eye, not only retinopathy, you can have cataracts, glaucoma, optic neuropathy. And can somebody read this? Yes. Yeah, we are endocrinologists and diabetologists. Sometimes we are boring, and many other fancy, specialty. They think of us like we have this necrobiosis lipotica diabeticorum. We are something, but this is something that we have seen it in patients with diabetes. That's and you see the grandpa will point here. I have something here and I have this. There's no treatment, steroids, something creams. But this is very common, and it's annoying for some of the patients.
Can you say it again?
Necrobiosis lipotica diabeticorum. Now to the questions. We have 10 questions, will be done. I think these questions we already mentioned it before, but somebody can read for us? Mm-hmm.
A 40-year-old woman presents to her family physician with diabetes routine follow-up. She's been diagnosed with type 2 diabetes and hypertension for 5 years. She takes metformin 1,000 milligrams twice daily and atenolol 50 milligrams daily. A1C is 7.1%, about 6 months per day. Blood pressure is 125 systolic or 80 diastolic. The physician may order all the following except.
So this is a patient with type 2 diabetes, and we try to monitor her for screening for microvascular and macrovascular. At the same time, we try to manage her overall. And we mentioned in the last lecture that diabetes does not come alone, usually followed or precipitated by high blood pressure, hyperlipidemia, other medical problems, metabolic disorder, obesity. They always come together. Polycystic ovarian syndrome, all this. So you want to check the A1C because due for A1C? Yes? You want to check the albumin in the urine because we want to screen for nephropathy, and we need to screen for nephropathy, also serum creatinine. We need to check for the lipid, blood pressure, all of this, but we don't want insulin level, right? When do we check for insulin level? The ghost of insulin. He wasn't there before. Insulinoma is a ghost. Yeah, we check insulin level when we are, and this is very interesting. Patients come to the clinic, I want to be checked for insulin resistance. Please check my insulin, the HOMA-R and the insulin and all. This is all, I don't want to call it BS, but it is. Because if you are obese, if you have fat in your body, you have insulin resistance. I don't want to go to the sea and fish, and if I don't get fishes, then I'm not in the sea. No, you have insulin resistance. You don't need to confirm it with HOMA. Okay, if you don't find it's negative today, the HOMA, in 1 month or 2 weeks, it's gonna be positive. So it's just like if you wait long, you will have it positive. And also the insulin level. Don't do insulin level, please. Just do A1C, do fasting blood sugar, do 2 hours GTT. If this patient was having type 1 diabetes, which one of the following regimen offer the best treatment? The best treatment. You just diagnose a patient with type 1 diabetes. Which one? Multiple injections of insulin a day. The natural beta cell insulin. Okay, is it 1 insulin or 2 insulins or how many insulins in the beta cells? 1 type of insulin. So why we have to have multiple injections?
Depending on the spikes.
So I can give the patient a long acting, right? So this long acting, somebody mentioned there is spikes of blood sugar, right? What you mean, like breakfast, lunch, and dinner, right? So why this insulin just follow the spikes? You inject a 24-hour insulin. Why it's not following the spikes? People in the back, did you hear the question? Why the long-acting insulin is not enough for patient with type 1 diabetes? Why this 24-hour insulin you inject at bedtime, when you wake up in the morning and you eat breakfast, why this insulin does not go up with to treat that hump of spike of blood sugar? Why cannot? Huh? So, but the human insulin does that, right?
But the drug is sustained release.
Yeah.
It doesn't compensate and increase.
Okay, thank you. Because it's not a smart insulin. In the future, inshallah, if you have a smart insulin, you guys, you can bring it to us. Right now, you tell the patient you have to take 2 types of insulin. 1 for 24 hours for the basal insulin for the fasting blood sugar, because your sugar cannot be 0. You always have sugar production from your liver, even if you're fasting, right? Because of the glucagon does that. If your blood sugar goes down below 70, glucagon go to the liver, cortisol go to the liver, adrenaline, growth hormone, all this will increase the blood sugar. The beta cell, the only beta cell to produce insulin to lower it. So you have to have between 70 and 99. That's a fasting. That's very tight range. We can do that with the 24-hour insulin. But once the patient is eating, okay, we don't have that. Patient have inject and another type of insulin. We can correct this in insulin pump. Insulin pump, we can program it, right? Same type of insulin, and when the patient eats, it gives more. How does it give more? Does it see? Doesn't have an eye? The patient press, the patient tell them, okay? But nowadays, they're working on what?
Sense.
Yes, it can sense that you're eating by blood sugar is gonna go up, but that's too much, too late. Because your pancreas is actually the healthy one connected to your eyes, to your taste, to your hand, to your mood. Okay, the vagus nerve, all these GI nerves, the neurochemical connection, that's make it unique. Until we have that, and even the insulin pump have insulin only, doesn't have glucagon. In order to be like a full artificial pancreas, you have to have the both. If you have low blood sugar, you have to have something to give you, okay, to control it. But still, we're not there yet. So nothing available right now except we have multi-injections per day because we don't have a smart insulin, and insulin pump. That's the only thing that we have that can mimic, but it's not can compare to the natural one. You have a question, please?
Doctor, at the very start of type 1 diabetes mellitus diagnosis, isn't there like a honeymoon period where there's excessive insulin release more than normal?
Not every marriage have a honeymoon period, by the way. Okay. And nothing in life has honeymoon. You don't have to have a honeymoon.
No, but for type 1 diabetes mellitus, there's a sudden release of insulin, right? Like an excessive release right at the start of diabetes.
Yes, but it's not everybody.
No, but then for those cases specifically, you wouldn't need multiple injections, right? You only need once a day.
Exactly. Sometimes the patient, when they leave the clinic, their blood sugar is so controlled, or leave the ER or leave the hospital, that they will need little by little. Like they go down from high for 10 units to 4 units, 2 units, and 1 unit, and sometimes they skip. And they say the family, the mother usually is happy, excited that is not needing any insulin, and that's true. But you have always to remind the family this is multi injections, is not one insulin. Always remind them, even if they have to leave the clinic or the hospital with 2 types of insulin. You cannot just give them the long acting. You give them the other one just in case. Take it with you, the one that's for me.
Isn't that put them at risk of hypoglycemia then, if they're given multiple injections with meals and as maintenance?
You always, when you give insulin, it's not like antibiotic. Always, it's the short acting is as needed. The long acting,
As needed,
okay, yes. So you will have the long acting. You give it to them just to, like, no type 1 diabetes patient newly diagnosed will go home with no insulin. Imagine after a week they have something. You'll be responsible. So you give them the lowest possible. To prevent DKA, you need 10% of your insulin capacity. That's what I mentioned always. 10% is enough to prevent DKA. So give them the lowest total daily dose. We have ways of calculating the total daily dose based on the weight, okay, of the patient. And to be safe, most of you, 10 units will do nothing to you. If I give any one of you 10 units now, nothing is going to happen. You have good glucagon, you have good liver, you're well fed, So 10 units is going to prevent ketosis, but it's not going to cause hypoglycemia.
Thank you so much, Doctor.
You're welcome. We need someone from that side to read question 2. Yes. Yes.
A 70-year-old man with PMH of type 2 diabetes mellitus and hypertension presents for a routine office visit, had unremarkable routine history and physical exam. His basic metabolic profile showed eGFR 39. Based on his eGFR, this patient has.
Do we need to have a proven damage to the kidney? Because it's below 60, right? Below 60, you don't need. So this is between 30 and 60. And that will be stage 3, right? So if I always have to remember this, 30 to 60. And in some literature, they divide them into 2, like 45, those 30 to 60, 30, right? Then 15. So 45 to 60, that's stage 3A. Stage 3B would be 30 to 45. Because most of our patients in the diabetes clinic will fall into this, and that's where we need to be careful and try to use ACE inhibitors, ARB, and medications to control the diabetes. Question number 3. Yes. The one with the hat, yeah. Read.
ACE inhibitor is the drug of choice for primary prevention of diabetic nephropathy.
False.
B.
The one next to him.
B.
False. It is for
Secondary.
secondary, right? Because that's when they were invented early, because they were so good that people thought to give every diabetic patient. But then there's a lot of diabetic patients, not all of them. Okay, so this was just like, sometimes you have to be careful. The guidelines and the pharmaceutical companies, they merit sometimes. You know, they have something to get. So that would be good. If I have a medication that everybody have to take, I'll be rich. You know, so we always have to be careful. So this is one of the things that they found later, that actually it's for secondary prevention. And why ACE inhibitor can damage the kidney, even though it's help the kidney. How does it help the kidney? ACE inhibitor? By lowering the GFR. Lowering the GFR, lowering the pressure that's coming through the nephrons, so protect the nephron from damage. At the same time, if you lower the GFR, that's the diagnosis of CKD, right? So initially, you'll have like a Nike effect, Nike sign. So initially there is a drop. Don't get scared. It will bounce back, not back to the normal that's before, but back enough for long term. It's better than doing nothing. Because that patient with type 2 diabetes, after 10 years, he will have lowering his GFR. But this patient is taking ACE, even though initially was lower, but it will not lower like the other one. Clear? You have a question here?
Doctor, what is the primary prevention?
Primary means the first time, without the disease.
What is it for diabetes people?
Controlling the type 2 diabetes. This lecture, everything we're doing here, try to prevent. Check the urine for microalbuminuria, check the serum creatinine, check the GFR periodically, lower the A1C to the normal range without hypoglycemia. This will protect your kidney. Lower the blood pressure, the hyperlipidemia. This is a primary prevention. Yes.
So if all of these are fine, we do not need to give them ACE inhibitor.
No. Only give ACE inhibitor if the GFR is coming down or the urine albuminuria is coming down. True or false? Microvascular complications of diabetes mellitus can be treated if detected early. We just answered that, right? So detect it early, we can treat it and correct it and reverse it. But the macro, difficult. True or false? Diabetes mellitus and hypertension account for approximately 70% of patients with CKD. True. Oh, I'm tired. Somebody read this.
A 34-year-old lady presented to a physician for prenatal care. She's 6 weeks pregnant. She developed gestational diabetes mellitus during 2 previous pregnancies. Her mother has type 2 diabetes mellitus. She's obese. What would you do next?
So she's at risk. When do you usually we order GTT for pregnant ladies?
After the first gestation.
No, let's say just a random lady who has never had any gestation diabetes. She has no family history of diabetes, nothing. She
4 weeks.
20,
24 to 28.
24 to 28, right?
Yeah.
So usually 28, but some people do 24, 26, 25, you know, that range. But some patients that's already at risk because of prior gestational diabetes, because of their mother has gestational diabetes or something, you have to do it. You have to always to think, you don't have to wait. But you do it early, so you do it B, order OGTT now, and again in 24 to 28 weeks. Another person read this? No, somebody else. The one in the middle here. Yes.
17-year-old boy known to have type 1 diabetes mellitus and multiple daily insulin injections was brought to the emergency room with polyuria, polydipsia, vomiting, and abdominal pain. He was found to be lethargic, hypertensive, tachycardic, and tachypneic. Laboratory investigations revealed pH 7.1, plasma glucose 515 milligrams per deciliter, urinary ketones is 4+, blood white cells are high, and renal function showed increased creatinine and urea. Which one of the following statements is true regarding his condition? E.
Okay, so let's summarize this. This 17 years old boy has what?
DKA.
DKA. Because he has, they have the acidosis, the diabetes, and they have the ketones, right? Which one of the following statement is true? Anion gap will be low. Okay. B, free fatty acids will be low. Will be high because it's a fat metabolism, right? Insulin level will be high. There's a lack of insulin. It's the opposite. D, blood CO2 will be high.
Because there's compensation, respiratory compensation would be respiratory alkalosis, right? So CO2, CO2 would be lower.
Will be low
Yeah, so E,
because of
respiratory alkalosis for compensation.
yes, and the bicarb will be
High, oh sorry, low,
low.
because of the gap, and then later on, right?
Yes, the bicarb will be low because of two things. Because of the it's being consumed to correct the acidosis, at the same time the CO2 production for the breathing. So in the kidney and the lungs, both of them, they consume the CO2 and bicarbonate. Again, DKA, just to remind you, this patient, when you read the stem here, is actually you trying to read it and look for those, your eye and your brain just looking for sugar, acidosis, low bicarb, ketones, anion gap, the potassium, what is happening, hypophosphatemia. You always try when you read the stem and then find out this patient has DKA. Patient has received insulin infusion, normal saline, and potassium per DKA protocol. When do you consider the patient is out of DKA?
B, no ketones. Anion gap.
Let's go one by one. Potassium level is normal? No, even potassium is misleading. As I said, could be high, could be low, could always to have to give potassium. No ketones in the urine? No, we don't care about the urine because pregnant ladies can have ketone in the urines. Fasting, dehydration can give you ketone in the urine. So ketones usually in the blood and the serum beta hydrobutyric acidosis. If the patient can eat, he's out of DKA. Anion gap is open. Anion gap is closed. That means low. So low acidosis. And by the way, this is very important. You will be like in the ICU as a medical student, and you will see a lot of things being done. Patient being rushed quickly to the floor. Patient being discharged home. Patient, without looking at the anion gap based on the pH, for example. They look at just pH. They look at the blood sugar is normalized. Patient is not needing insulin. Okay, they have to turn off the insulin drip. They should always look for the anion gap. Look for bicarb or the bicarb. Question number 8. What are the known precipitating factors for his condition? Which one?
Doctor, can you go back to the
Go back to the
session
question.
step?
Here?
Yes.
You want to know, you want to read this so to answer the question? Okay, read it.
It's infection, right? It's blood vessels. Doctor, would it be infection because WBCs are high?
Could be anything. But the question is not about that.
Oh, okay. For
Also,
every,
any patient-
every type of
Yeah, it's known. What are the known precipitating factors for his condition? Yeah. So he could have, because he missed insulin dose, could be UTI, could be pneumonia, could be cardiac ischemia, always have to come. So when they call you to go to the ER to see a patient, you always come with your bag. Don't go empty, just like, oh, I have a patient DK, run, just like this. Always open your book and try to see what should I do, what's precipitating factors could. And then when you go, look for the sign, how he breathes, listen, pneumonia, did we get a urine, did we get a chest x-ray, what is happening? You always, be ready when you being called. When you called about any patient, always have 1, 2, 3 differential diagnosis, 1, 2, 3 exams you need to do, 1, 2, 3 tests you need to do. That's usually the case. Okay? Which of the following is an example of macrovascular complication of diabetes? Macro? E. Right? The first one is micro. Autonomic. The last one is macro. You'll see this in exam, I guarantee. And this one? Yes, an easy one, right? All right, thank you so much for listening. Okay. Good luck in the exam.